Thanks so much. Hey everyone, my name is Dan. One of the second-year residents presenting today for Academic Half Day. My talk is on acute decompensated heart failure. So I chose this topic because it's something we see quite commonly. And the thing about it is that there are just so many steps to the management. I want to take a deeper look into the understanding of the reasons we do the way we do it. As you guys probably have experienced already, we see this presentation from intern year at the VA all the way to our third year at Harborview. And there are so many different ways we can go about doing things. And so I wanted to dive into that a little bit further. Disclosures, I have none. Objectives, first, to appreciate the increasing prevalence and incidence of heart failure. Recall the diagnosis of acute decompensated heart failure on exam, examine the evidence behind management, an intro to cardiorenal, and identifying the contributing factors, and also a little bit of treatment on diuretic resistance. So brief epi, we know that there are 6.2 million people with heart failure in the United States between 2013 and 2016. An estimated 23 million worldwide in that time span. But we also see an increase in both the prevalence and the incidence with age. And this is pretty expected. Reasons why really are better management of the risk factors we know to contribute to heart failure. The most obvious one being things like coronary artery disease. But as you see here, increasing prevalence in the first age group for both men and women, which are comparable. 8 per 1,000, but later in life up to 66. Similar increase with incidence you see here. But there is a difference between the trends that we see in HFpEF versus HFrEF, and I think I wanted to highlight this in particular. These images are taken from a study that was published in the New England Journal back in 2006. It was a single institution study, but they looked at the trends and their admissions over a 15-year period. And what they saw was that there was an increase in the prevalence of heart failure, the preserved ejection fraction, an increase in the number of admissions with HFpEF as well. That was statistically significant. Not as much so, though, for reduced ejection fraction in terms of the change. And the reason why I think I wanted to highlight this out in particular in a talk about acute decompensated heart failure is that HFpEF is an increasing presentation in terms of heart failure admissions. And so ejection fraction alone, in the right clinical context, of course, should not be a major factor in thinking about a differential in someone presenting with shortness of breath. Similarly, these images are taken from that same study. And to further drive that point home, we see that survival in HFpEF was similar to HFrEF. Beyond that, if you look even closer in the different colors, you see that there is improvement in the survival in patients with HFrEF over that time period in 15 years. And we don't see as much of that change in HFpEF. So not only is the survival comparable, we haven't seen as much improvement in that population as well. So just want to emphasize that HFpEF is certainly not a lesser version of HFrEF as we know it. So take home point number 1, acute decompensated heart failure should remain high in the differential despite the presence of a preserved ejection fraction. Of course, in the right clinical context, in presence of diastolic dysfunction as well. So moving on to our case, we have Mr. Yuri Nate, 65-year-old man. He's got a history of HFrEF, hypertension, hyperlipidemia, coronary disease. He presents with a couple weeks of shortness of breath and lower extremity edema. Home meds include losartan, metoprolol, MPAG, furosemide, and spironolactone. His blood pressure is 110/62, heart rate a respectable 101, JVD to the mandible, lungs with diffuse crackles, extremities warm, well perfused, and pitting edema. Don't really mean to belabor the diagnosis here as the talk is on acute decompensated heart failure, but just wanted to highlight the initial triage that we hear we think about when we get this phone call. Things that I always hone in on are the vitals that we get. Certainly, hypotension can be concerning for shock. Hypertension can also cause patients to decompensate. Narrow pulse pressure is less than 40. Other things we think about in terms of evaluating for a low output state. But something for me personally that's most concerning always is patients with tachycardia, which can often quickly deteriorate before us. So after we hear about this patient, we head down to the ED to meet him. And we think about getting a history. Now, in the chat box, if you guys want to, feel free to like enter in some of your favorite phrases that you like to ask the patient, because there's so many different ways that it can take shape. So I was curious as to if anyone has any things that they like to use. But the presentations of heart failure essentially, when we're gathering our history, can be broken down into three main etiologies. It's either worsening of chronic heart failure through dietary, medication, hypertension, substances, or non-cardiac processes like infections, things like that. New worsening cardiac process, ischemia, arrhythmia, hypertension, and then de novo heart failure, the one we see for stress-induced cardiomyopathy, myocarditis, acute fibrillary insufficiencies, maybe sometimes even while patients are in the hospital. One thing that I wanted to point out actually that I think was, that I thought was particularly interesting was the medications, not only adherence, but contributing medications that can cause heart failure. We know about beta blockers, calcium channel blockers, things like that, that can definitely cause patients to decompensate. But I also, learned more about medications that, for example, contain sodium or have sodium retaining properties. In particular, antibiotics are one thing that I honed in on because we use those so frequently in the hospital. Metronidazole has 800 milligrams of sodium per 500 milligram vial. Piptazo, 120 milligrams per 2.25 gram vial. Polyethylene glycol has a 1.5 grams of sodium per liter. And things like NSAIDs can actually lead to sodium retention. So kind of things that I thought were interesting that I learned about in this talk. But yeah, asking the right questions is super key. Let's see, is there anything in the chat box?
Nothing so far.
Okay. Well, the things that I think about really are, not only how many pillows a patient uses, but why they're using it. Not only if they are waking up in the middle of the night, but why. And one of my one thing that I always want to emphasize too is normalizing the difficulty of salt restriction in ambulatory settings. I often phrase it like, salt is often hidden in many different places. Do you ever feel like you ever have to add anything here or there?
I have a question in the chat, Dan, about Miralax and the sodium content. Wondering if it just stays in the gut or if that's incorrect and you actually should worry about fluid retention. Yeah.
Honestly, I don't know the answer, but I would imagine that it primarily could stay in the gut, especially with the amount of, diarrhea that a patient is often having. I'm not sure if it's been studied thoroughly, and I doubt it has been, but certainly can be considered. But thanks for asking. So when we think about clinical presentations of heart failure, you guys have seen this chart before, the table that it's broken down into. Certainly we like the warm and dry patients are really the happy ones, and the cold and wet ones are the ones that we get the most nervous about. Warm and dry patients actually make up, I think, about 70% of these admissions, whereas the cold and wets make up the 20% and the remaining two, the 10%. Of course, the cold and dry patients, for me at least, are the most worrisome because while they might look okay, where they fall on the curve, they can quickly decompensate. But yeah, quick review of kind of the 4 different areas and different presentations of these heart failure admissions. But now we go down to the emergency room and we get a chance to evaluate our patient, Mr. Nate. And I wanted to review quickly, the different exam maneuvers we do and how, they make us think more or less of heart failure. So things that are more likely is a third heart sound. And S3 is known to be pretty specific in terms of being specific for heart failure. A chest film as well, specifically a chest film showing interstitial edema versus venous congestion. Same for hepatojugular reflex, a history of heart failure, as well as JVD. Things that are less specific, crackles, peripheral edema, and orthopnea. But wanted to hone in on one or two of the physical exam, particularly the JVP measurement. I'm not sure if you guys, some of you recognize this particular video. Let's see if I can copy and paste it into the chat. JVD is definitely one of our considerations when we're presenting, when patients are presenting with heart failure. As you know, it's an estimate of the right atrial pressure. Therefore, it's not a direct measurement of left ventricular filling pressures. Increased right atrial pressures can also be caused by things like pulmonary hypertension, tricuspid valve disease, and stenosis, as well as SVC obstruction. I've actually learned to break down a JVD measurement into two steps. One with a patient sitting upright at 90 degrees and seeing if you can see the JVP above the clavicle, and then you for sure know it's elevated. But then if not, reclining the patient 30, 40 degrees, which can give you maybe a more granular or nuanced determination, which could be helpful, maybe more so on a day-to-day basis. And over the years, ultrasound has become more and more popular, and it's become very common for us to quickly measure someone's IVC when they're down in the emergency room, or even on a day-to-day basis. B-lines as well, but something that I'm not addressing in this talk. For IVC measurement considerations, some of the technical limitations to always consider is the point of measurement. Making sure you are in the right plane to get the largest diameter that you see. But also for those who are a little bit more advanced, looking at making sure they're perpendicular to the IVC, foreshortening, as well as inter-rater reliability. Some confounding factors. We think about thoracic factors, particularly related to a patient's respiratory rate. Distant patients can cause maybe over collapse versus weaker patients can under collapse their IVC. Cardiac factors, including RV dysfunction, in which patients might have chronically enlarged IVCs, and abdominal factors such as ileus or elevated intra-abdominal pressures. And so the take-home point here I wanted to emphasize was that the volume exam is super challenging, which makes it super important to utilize multiple data points instead of one. So continuing the case, we have the labs that are now back. BNP is 2000, baseline of around 500, troponins are negative, chest film, as I mentioned, pulmonary edema, some cardiomegaly, ECG, normal sinus rhythm, left ventricular hypertrophy. Labs otherwise on the CMP looking pretty baseline, creatinine close to that as well, and other notable electrolyte abnormalities. Kind of honing in on a few in particular. BNP, as you know, has been a very huge or important factor in determining patients who are coming in for heart failure. 100, the value of 100 has been found to be quite predictive of heart failure. But having more of a nuance, considering where patients might have a baseline elevation, particularly in patients, who may have coexisting heart failure, atrial fibrillation, or chronic kidney disease. As you know, the nuances in BNP also are considered in patients who have an elevated BMI, in which it might be lowered as well. Troponins, they're negative. Sodium is one thing I also want to point out, as a low sodium is a predictor of all-cause mortality, particularly when they are less than 125. Creatinine, we'll talk a little bit more later. And the ECG, less so in terms of the diagnostics of heart failure exacerbations, but more so to give us a sense of what the etiology might be. For example, if any arrhythmias are present or any evidence of any prior ischemia. So moving on, we are now, diagnosing this patient with acute decompensated heart failure and thinking about the first dose of diuretic that we want to give the patient. A study that I learned and I've heard quoted very frequently is the DOSE trial that was published in 2011. Essentially, it was a randomized trial that looked at bolus versus continuous at low and high doses in patients with heart failure. And they found that they were not statistically different. Things that were also determined from the study was, what recommended starting dose to give the patient, which was 2.5 times the home dose in IV form. So, for example, in our patient who was taking 40 milligrams of PO furosemide, that would be 100 milligrams in IV form. There has been a lot of talk about this trial since then and how the methods were done, particularly when it comes to continuous versus bolus infusions. As they reported, there was no difference in symptoms. However, there are some things to point out. And one of them was that there is an argument that these patients were not given an initial bolus before starting the continuous infusion. And so maybe they were inadequately treated, which resulted in no difference. A second thing to point out is that these were patients who were randomized for initial therapy, continuous versus bolus infusions. And so really, it does not really investigate the situations where we are running into diuretic resistance, which I will touch upon later, where there may be a need for continuous infusions, particularly to reach higher daily doses of the loop diuretic. And then finally, there could be some benefit in using continuous versus bolus and reaching or avoiding peak effects, particularly when it comes to avoiding hemodynamic changes or avoiding ototoxicity. Yeah, that's a great question, Sophie. I believe the study was done primarily looked at different diuretics. And so I think that you can use the 2.5 for different diuretics as well. One thing that I have tried to do in thinking about patients on different diuretics is similar to how we think about opioids and like converting to something like a furosemide equivalent and then going back to what other diuretic that they might be on. But that brings up a good point in comparing the loop diuretics. I always have to look at this table, especially when I'm admitting patients on different diuretics and knowing what the equivalents are. The big thing to point out is for furosemide, bioavailability being quite terrible, ranging from 10 to 100%, the average being around 50%. Things to point out about bumetanide is that unlike furosemide, bumetanide levels are not as heavily affected by GFR. And the reason why this is important is because we have a lot of patients who are admitted with heart failure, but also have comorbid chronic kidney disease, which we often think about having higher, requiring a higher threshold of diuretic, upwards of 100 to more than 100 milligrams. But dosage adjustments might not need to be made for bumetanide. Also, for patients who are on continuous infusions, there are reports of something called syndrome of severe pain that has been associated with continuous bumetanide infusions as well. And then finally, torsemide and bumetanide are metabolized by the liver, which is a little bit different than Lasix. But for all of them, things to look out for are primarily ototoxicity and hyperuricemia. So we check in after running upstairs and working on another admission to see Mr. Nate after a couple hours, and he's already feeling slightly better. His first dose was about a couple hours ago, and his urine output is about 500, which made me wonder, what is our goal? So many times I feel like on rounds, when we're thinking about patients, we ask ourselves, what is the target? Is the diuretic being effective? In my literature review, it was hard for me to find actually a definition of clinical response to the initial dose. What I did find that was quite uniform in guidelines was to monitor the urine output 2 hours after the first dose, because you should and you will see an effect of the diuretic at that time point. This is particularly important because studies have shown that patients who are receiving diuretics have in-hospital mortality benefit and received earlier. And so when you think about these patients that are admitted, 9 o'clock at night, and really only window to receive one dose of diuretic, it's really important to get ahead of it and make sure they're reaching their threshold. But there is another emerging method that I've been seeing. One of them is through urine, checking urine sodium. Hasn't been yet tested in large studies. I can imagine in the years to come that this could be a modality that's done in conjunction with monitoring someone's urine output. One thing that I did want to highlight here is that we see that our patient is already feeling slightly better, despite having a urine output of only 500 cc's when they are probably at least a few liters volume overloaded. And the reason is that there was a study years ago that furosemide and possibly other loop diuretics have an initial morphine-like effect in causing a vasodilation similar to what we see in morphine. So we can actually see an improvement, maybe from a volume perspective, but also from a venodilatory perspective in patients very soon after Lasix administration. Great, thanks. So many references. At this point, I began to wonder whether there are differences in the management for acute decompensated heart failure in patients with preserved versus reduced ejection fraction. There was a study last year done where they investigated this difference, and they found that volume overload in patients with HFpEF appeared to be attributable more to interstitial instead of intravascular fluid overload. So therefore, circulation might be more sensitive to intravascular volume reduction in diuresis than in HFrEF. There's a follow-up study done that showed that plasma volume reduction was associated with a worsening renal function in HFpEF versus HFrEF, maybe because of this reason. And I think that this was particularly enlightening, looking back to see, how this makes sense in the context of what we know about the dose trial. The dose trial, the mean ejection fraction in that study was 35%, and only a quarter of those patients had injection fraction greater than 50 without any subgroup analysis. So it makes me wonder, really, should we be thinking differently about how aggressive we are in terms of high versus low intensity diuresis in patients with different etiologies of their heart failure? Yeah. So after meeting our patient and getting a moment to kind of gather ourselves, we are ready to do a med rec, thinking about what medications should be continued on hospital admission versus not. As you know, this patient was on all the good stuff on quad therapy with a beta blocker, ARB, MRA, as well as SGLT2 inhibitor. From like personal experience, I have to say, like, a lot of times the gut instinct is to hold all their medications, especially while they're sick and potentially hemodynamically unstable. But one that I want to particularly point out was beta blockers. There's something called there's a trial called the Optimize HF trial, which was investigating whether or not continuing beta blocker therapy on admission was associated with better outcomes. And they actually found that it was so, and discontinuing was associated with increased mortality. Now, part of that could have been that if discontinued, it was more likely to be continued to be held even on discharge. And so the effect on mortality certainly extended beyond the hospital admission. But we also know that there is an association between abrupt cessation of beta blockers with hypertension, ventricular arrhythmias for sure, and even in some cases, ischemia. I have to say that it's tricky. We have to think about the reasons why a patient is being admitted. Are they admitted due to a recent dose increase, things like that? And certainly that would be a reason to hold the medication. But just a few things to consider. Other medications to consider are ACE inhibitors, ARBs, MRIs, SGLT2 inhibitors. Particularly for the ACE inhibitors and ARBs and ARNIs. If we think about the mechanism of ACE inhibitors in terms of dilating the efferent tubule, really the main effect on causing renal injury can be in hypotension and decreasing renal perfusion, as well as issues with hyperkalemia. You could argue that also continuing these medications could help with afterload reduction and augmenting diuresis as well. But will certainly hold in the setting of hemodynamic instability. Now we're looking into the housekeeping portion of our admission, checking their fluid, electrolytes, and the nutrition. One thing that I learned last year was the 2-liter fluid restriction and the series Things We Do for No Reason, which is a really interesting series that kind of points to things that we do in medicine where we don't necessarily know always the reasons why, but we do it because that's what we have always been told. So there's a small study that they presented where patients were randomized to liter versus liberal intake, and they show no difference in the duration or dose of diuretics, time to improvement, total daily output. But the sample size was limited as it was only in the 60s. So there was a follow-up study where patients were randomized to aggressive fluid restriction of 800 cc's per day, as well versus liberal, and it showed no difference. And so interpreting from these two studies, maybe there is an argument that we shouldn't be fluid restricting patients who are coming in with heart failure exacerbations. There are a couple situations where they did point out it is beneficial. And those are in patients who are presenting with heart failure and hyponatremia, as well as those who are challenged with diuretic resistance. Also want to point out that these two studies were done in patients with reduced ejection fraction, as many studies are, and not with preserved ejection fraction. Sodium restriction is also one of those things we commonly do, and we'll probably continue and will continue to do. I only bring this up because actually this past month, there's a trial that was published called Sodium HF that showed that sodium intake in the outpatient setting did not significantly reduce major adverse cardiac events in heart failure patients. but did modestly, as you imagine, improve their quality of life. But looking into the study, the control group was limited to 2 grams of sodium, and the low sodium group was only consuming about 1.6. So pretty small difference. So hard to take anything away from the study yet. So for me, certainly still limiting patients with a sodium restriction. And then for electrolytes, think about potassium greater than 4, mag greater than 2. The context behind that is that there was a study done among patients with acute myocardial infarction, and they found that the lowest mortality was observed in those with post-admission potassium between 3.5 and less than 4.5, compared to those who had higher or lower potassium levels. In other words, there was increased morbidity and mortality in patients with potassiums less than 3.5 and greater than 4.5. The bottom line is we've used that study to kind of split the difference and target a potassium of 4. But really, in patients who are admitted with something like 3.8, maybe we don't need to be so aggressive in making sure that we're targeting greater than 4. Of course, in the context of checking electrolytes twice a day with ongoing diuresis. Question from Roshan.
Yeah, go ahead. Sorry, I was about to read it to you.
Yeah. Thoughts on a 2 gram sodium restriction in a patient that is not adherent to similar diet at home? Are we optimizing diuretics for an unrealistic diet for them? Yeah, that's a really good question, and one of those things that I think we are challenged a lot when we discharge patients and kind of setting them up for success. That's something that I don't actually know, but I think, when we talk to patients and continue to educate them, it's something that we always need to emphasize, making sure that we try to emulate as best as possible on the home environment for them and continuing that on discharge. But good question. So take home point number 3, reconsidering holding chronic heart failure medications as well as strict fluid restriction, and certainly in mild decompensations. Case continued. So we have labs from hospital day 2, and here we have it. We have a creatinine bump. Other things we can, maybe point out is maybe an uptrend or downtrend in the chloride and increasing bicarb as well. But leads to the next point of a creatinine bump and metabolic alkalosis. So as you guys have probably seen quite frequently, creatinine bumps are certainly not uncommon, especially in admission for heart failure exacerbations. There was a post hoc analysis done of the dose trial, and they actually saw that a rise in creatinine up to 0.5 during admission for decongestion was actually associated with improved outcomes. And the reason maybe is that these patients were receiving better diuresis during this hospital course. Of course, it's always hard because there's so much ambiguity in the volume exam. As I mentioned before, there's only so much we can determine, from lower extremity edema. Hard to know from the JVD when to stop diuresis in the setting of creatinine elevation. There has been some thought that this may be explained instead by hemo concentration, and when patients are volume overloaded, and there might be an aspect of hemodilution and they do get diuresis, and a creatinine is elevated to maybe more reflective of their true creatinine levels. But also important to keep in mind other etiologies of AKI, certainly checking a PVR, especially in our veteran population. One thing that I also wanted to point out was the rise of the bicarbonate, particularly on metabolic alkalosis that we often see in patients who we are actively diuresing. First thing that I wanted to point out about metabolic alkalosis and diuresis are patients who have COPD to be, keeping an eye. on their respiratory status and whether or not they can start to retain CO2 to compensate for metabolic alkalosis that diuresis causes. One other thing to consider, and a little bit above my head, but there is a sodium channel. There's a channel in the nephron called pendrin that is a sodium bicarbonate exchanger that removes bicarb and resorbs chloride. So pendrin activity actually decreases in settings like hypokalemia, elevated aldosterone, and chloride depletion. And so aggressive diuresis can lead to chloride depletion and hypokalemia, which can decrease pendrin activity in removing the bicarb, which can explain why the bicarb is certainly elevated. One thing I wanted to point out that was relevant when I was on H wards in the fall was when we had a shortage of potassium chloride. I'm not sure if that's still true. And potassium acetate was an option. One thing to know is that potassium acetate can be converted to bicarb by the liver. So, hopefully there isn't a shortage anymore, but, in terms of avoiding metabolic alkalosis, favoring potassium chloride when we're plating. So take home point number 4, think about the trends and significance of all the lab values when we are admitting a patient with heart failure. But I can't talk about creatinine elevation without mentioning cardiorenal syndrome. The definition being a bidirectional interaction between heart and kidneys, encompassing both effects that impaired heart function have on renal function, as well as the impact of renal injury or CKD on cardiac function. As we know, one of the mechanisms of cardiorenal is volume overload itself, which increases the venous afterload and impedes forward renal flow. But one thing that I think is less commonly thought of is a concept called plasma refill time. And so when we think about the location of fluid in the interstitium versus in the intravascular compartment, diuresis initially removes fluid from the intravascular component, and then later it's refilled from the overhydrated interstitium. And so, and this is a result of hydrostatic and oncotic pressures. But when you think about the plasma refill time, it is the time required for the extravascular edema to refill the intravascular volume that is being diuresed. And so when we think about how fast that refill time is, for example, maybe it's only 2 or 3 liters per day when we are diuresing someone with a urine output up to 5 liters per day. Maybe that is not keeping up with their intravascular volume, which could be one of the proposed mechanisms of cardiorenal syndrome. It can be classified into 5 different ways. The most common, as we suspect, is type 1. We know that perfusion of any organ is related to difference between arterial and venous pressures, and increased venous congestion can limit that perfusion. Most patients with acute decompensated heart failure actually come in with a preserved cardiac index. So forward flow actually often isn't even the issue. And then when we think about diuretic resistance, it's helpful for me actually to think about the mechanism of diuretic resistance by thinking about the steps necessary for a diuretic to take effect. First of all, ingestion and GI absorption, really only pertaining to PO intake. Delivery to the kidney, secretion into the tubule, and binding of transport proteins, particularly albumin for loop diuretics. And then finally, won't go into intense detail, but in terms of the treatment of diuretic resistance, we're commonly seeing more and more the idea of sequential nephron blockade. So, here is an obligatory picture of the nephron. And oftentimes what I've seen is loop diuretics, of course, are started. And the first line adjunct is a thiazide-like diuretic, specifically metolazone. But then afterwards, we think about other targets of the different areas in the nephron, we can consider MRAs for patients, particularly who are requiring potassium for hypokalemia, acetazolamide in patients who are facing metabolic alkalosis. So really depends, and there is no formulaic way to go about it. And then some of you have also probably experienced hypertonic saline as well, particularly if you might be at UW with the assistance of the cardiorenal team. But still a lot to be studied regarding that method. Okay, so take-home points. Acute decompensated heart failure should remain high on the differential despite the presence of a preserved ejection fraction in the right clinical setting. Volume exam is challenging. Utilize multiple data points when you can. Reconsider holding all chronic heart failure medications on admission. Think about the trends and significance of all lab values on the chemistry. And appreciate the multifactorial etiologies of diuretic resistance. Here are my references, and thanks for your time.